Fellow of Female Pelvic Medicine and Reconstructive Surgery. Thank you for the opportunity to present our work. I will present our project entitled Cystoscopy with Antibiotic Irrigation during Pelvic Reconstruction and Minimally Invasive Gynecologic Surgery, a double-blind, randomized controlled trial. And this was conducted at Metro Health Medical Center. We have no disclosures. The incidence of urinary tract infection after pelvic reconstructive surgery is high, reported up to 27%. Cystoscopy is routinely performed at the time of hysterectomy and pelvic reconstructive surgery and may represent a source of postoperative UTI, but also a potential target for infection prophylaxis. Intravesical antibiotics are successfully used as prophylaxis and treatment of UTIs in the outpatient setting and may be applied to the surgical arena. An older trial in 1981 first reported successful use of antibiotic bladder irrigation during cystoscopy, but there have been no contemporary studies on this topic. We performed a double-blind, randomized controlled trial with the objective of evaluating the effectiveness of an antibiotic irrigation at the time of cystoscopy performed in women undergoing benign gynecologic surgery. We hypothesized that rates of postoperative UTI will be lower in patients who receive the antibiotic irrigation. We recruited 239 women undergoing elective pelvic organ prolapse or stress urinary incontinence surgery or minimally invasive benign gynecologic surgery. Patients were excluded if they had a preoperative urinary tract infection. Participants were randomized 1-to-1 to irrigation type for intraoperative cystoscopy. The control group received normal saline irrigation, and the antibiotic group received a solution of Neosporin GU in normal saline. The study was doubly blinded by concealing the irrigation type from both participants and the attending surgeon, who would be the individual responsible for diagnosing and treating postoperative urinary symptoms. Subjects were also contacted at 3 time points postoperatively through 6 weeks to evaluate for UTI, adverse events, and lower urinary tract symptoms. Our primary outcome was the rate of UTI within 6 weeks after surgery, and we utilized the CDC and NISHN definition for our definition for research purposes. Our secondary outcomes included the incidence of UTI within 2 weeks after surgery, rate of UTI among patients undergoing a vaginal reconstructive procedure, which is a surgical cohort at highest risk for UTI, and adverse events related to antibiotic irrigation. Ultimately, we enrolled 239 women. 12 were excluded for preoperative UTI. We also collected a urine culture upon Foley catheter placement in the operating room, and 11 had a positive culture at that time, leaving us with a final study cohort of 216 women. The study groups were very well matched, with no differences in demographic characteristics, medical comorbidities, or type of surgical procedures performed. Mean patient age was 51.6 years, and the majority of subjects were Caucasian, premenopausal, and obese. This shows a graph of the overall types of procedures that patients underwent, which did overlap. 58.8% of women had a primary vaginal surgery. 27.3% of women had vaginal prolapse repairs, and this also includes 28% of women who had an isolated mid-urethral sling placement. There's some overlap because some women had both a laparoscopic and a vaginal procedure, such as if they had a mid-urethral sling or vaginal prolapse repair, in addition to primary laparoscopic or open surgery. The mean volume of cystoscopy fluid was similar between groups. Ultimately, a urinary tract infection was treated in 10.7% of patients overall within 6 weeks, and there was no difference in total UTI incidence between study groups, as you can see, with 9.9% of patients having a UTI who received normal saline, and among patients who received the antibiotic irrigation, 11.4% of patients developed a UTI, and this was non-significant. After adjusting for possible confounding variables on multivariable logistic regression, postoperative UTI rate remained independent of irrigation type. In terms of secondary analyses, on a sensitivity analysis of UTI diagnosed within 2 weeks of surgery, or when considering only patients who underwent vaginal prolapse repair, the rate of UTI remains equivalent between study groups. There were no adverse events related to the use of antibiotic irrigation. The lack of any difference between groups may be multifactorial. Most likely is that any potential benefit of antibiotic irrigation may have been diluted by the risk of procedures performed in addition to urinary instrumentation. Cystoscopy was a small portion of the surgery for these women. In fact, prior retrospective reviews have demonstrated additional concomitant surgical procedures to be a risk factor for UTI after hysterectomy. Therefore, we propose that future evaluation of intraoperative intravesical antibiotics should focus on cystoscopy-based procedures or in patient populations at highest risk for UTI, such as patients undergoing a vaginal reconstructive surgery only or patients with recurrent UTIs or chronic asymptomatic bacteriuria. The limitation of this study most notably included the mix of procedure types and approaches, so it was underpowered to detect a difference between any particular subgroup, such as those undergoing vaginal reconstructive surgeries. Overall, in this prospective randomized controlled trial, we demonstrate that the use of neomycin polymyxin irrigation with cystoscopy at the time of elective gynecologic pelvic surgery is not better than standard irrigation for prevention of postoperative UTI. Thank you.